And by the way, the people who learn those CBT skills are more likely to remain panic-free after coming off the medicine. The people who say, no, I just want to take medicine, I'm not going to learn the CBT, they're stuck on the medicine. Because if they try to come off of it, they have another panic attack.
What happens to the old brown bag, that trick? They're supposed to do that, breathe into a brown bag.
When someone is hyperventilating, right. No, that's something different because that person is taking breaths that are too deep, not shallow. In social anxiety disorder, it's a fear of embarrassment, a marked or persistent fear of one or more social or performance situations in which the person is exposed to unfamiliar people or to possible scrutiny by others. The individual fears that he or she will act in a way or show anxiety symptoms that will be humiliating or embarrassing. That's really the hallmark, you know. I'm not going to raise my hand, I'm not going to speak in this room because I'm going to say something and other people are going to think that I'm foolish or stupid. It's all this negative self-talk that is increasing your anxiety. And so you avoid, because you've taught yourself that if you just avoid the situation, there's no chance of experiencing that fear or embarrassment. Now, we all have experienced this to some degree. It's when it's severe and incapacitating, when it's causing distress or dysfunction, that we would classify it as a disorder. And the treatments can be very effective, very similar to panic disorder, medicine, and CBT, you know, learning, exposure, response prevention, actually coming into as many social situations as possible, focusing on the other person rather than, oh, I'm afraid he's thinking this about me, I'm afraid she's thinking this about me. No, let me listen. What are you saying? Okay, I'm going to take a risk. I'm going to respond to this person. And then I just heard your response, which confirmed that what I said was okay, good. I've just built some confidence. And just practicing that kind of thing.
Would stage fright be similar to that?
Yes, stage fright is a simple form of social anxiety disorder, yeah. OCD, I mentioned earlier, remember that dorsal striatum? In OCD, there's a loop in the brain. Well, let me describe this first. Recurrent and persistent thoughts, impulses, or images that are experienced at some time during the disturbance as intrusive and inappropriate that cause marked anxiety or distress. So these thoughts keep coming into your head over and over again. And you have paired those thoughts with the behavior, sometimes inadvertently, sometimes what appears to be in a logical way. So for example, did I lock the door of my car? I don't remember if I did. Could you all excuse me for a minute? I got to go out and check. Right? So I go, I check, the door's locked. I come back, the door was locked. Oh, I think it was locked. I can't give myself that sense of relief until I actually go and carry through the behavior. The behavior decreases my anxiety for the moment. But then the doubt builds up again. I engage in the behavior, my anxiety is decreased. See, decreasing the anxiety is what keeps driving the behavior in a positively reinforced way. I know how to get rid of my anxiety. Engage in this behavior. And there's the loop. Now, in the brain, what that looks like is that dorsolateral prefrontal cortex, responsible for working memory, right? That, the dorsal striatum, the thalamus, which is a part of the brain I haven't mentioned before. The thalamus is sort of a relay station. Helps coordinate the information that's coming from the body up into the brain, through the thalamus, and to various parts of the brain. That's part of the loop. So dorsolateral prefrontal cortex, dorsal striatum, thalamus, back to the dorsolateral prefrontal cortex. And on a functional MRI, you see hyperactivity of this loop in somebody with OCD. The treatment, all anxiety disorders, medicine and CBT, obsessive, cognitive behavioral therapy. Particularly, again, exposure and response prevention. So I'm exposed now. I have the thought. Did I lock the doors? Now it's building anxiety. Oh no, what if I didn't? What if I didn't? What if I didn't? My car's going to get stolen, right? I have to sit with this though. I can't act on it. I have to sit with it until something happens that I didn't let myself experience prior to this. So I didn't know it would happen because I had already found a way to decrease the anxiety. I would run to the car. Now I'm learning a new way to decrease the anxiety. Sit with it. Wow. As I'm standing here and I'm not going to the car, it's decreasing anyway. I didn't have to go to the car to decrease it. It might be unlocked. I'm just going to have to accept that. Accept the doubt. Not act on it. My anxiety's gone. That's essentially the way it works. Usually people with OCD have multiple behaviors associated with their anxieties. And so we look at and create what's called a hierarchy. Those that seem just impossible to resist. No, I can't give that up. I have to do that. My anxiety goes through the roof if I don't do that. All right, so that's the last one we're going to work on. But as we look at the individual behavior, we discover that there are different intensities of anxiety associated with each one. So we find the one that has the least amount of anxiety associated with it. That's the first one we're going to engage in. Right? You have this need to put the light on and off 3 times as you go into the bathroom. You don't feel comfortable unless you do it 3 times. We're going to try this. You're only going to do it twice. We walk in, do it once, do it twice. All right, that's it. Okay, you're anxious. You have this need. You want to do it a 3rd time because you've convinced yourself that if you don't, something terrible is going to happen today. We got to take that risk. You're not going to do it. Let's see what happens to your anxiety. All right. Is there anything else we can do right now? How about washing your hands? Okay, good. Wash your hands. Dry them. Let's walk out of the bathroom. The anxiety starts to decrease. Wow, I didn't have to do it the 3rd time. Oh, I get this. I can do this. Start building confidence. Now we go to the next behavior, et cetera, et cetera. Gratifying to treat. Very effective treatment. People do well most of the time. It's nice. Medicine can help that. Augment the process. We use antidepressants. Yeah.
Like the business world, they would say go after the big, like a high impact activity. Like they would say, the business world calls like the 80-20 rule, like go after the hardest one because that's going to have the most impact, right?
Yes.
That's why it's if I say medicine, or the same rules don't apply. Because if a company would say, Apple would say, work on some little product, no one would have to be a complete waste of time. So they go,
That's interesting. But you reminded me of something that I've forgotten about. And that is this therapeutic intervention called flooding. And that essentially is just what you described. So in the case I gave, it would be finding that behavior associated with the greatest amount of anxiety and working to convince the patient to work on that one first.
that's another school of thought,
Yes.
which is probably not as good as the one you described.
Right. No. Because the thinking is all the others will just float away. You've tackled the most difficult one.
Yeah, that's the traditional, probably American capitalist way of looking at it. Why waste time on the little ridiculous things?
You're not going to see that patient again if you try it. He's not coming back for a second appointment. It would be effective, but they don't trust. They haven't had any confidence that this is going to work. You're expecting them to trust you too much. They don't do it because they're anxious to begin with, remember? Yeah. So it's ironic because it would be effective, but they won't do it. You won't get them to do it. You have to build the confidence. In PTSD, we see increased arousal. What does that look like? People are hypervigilant. They scan the environment. Is there anything in here that can hurt me? Exaggerated startle response. They jump easily. Difficulty falling or staying asleep because they're too revved up all the time, 24 hours a day. Cannot just relax and go to sleep. Avoidance and numbness, decreased emotional expression, very irritable or outbursts of anger. Now we know that specific parts of the brain are involved. Remember the hippocampus, the amygdala being responsible for fear and anxiety. We see that the amygdala is overactive in PTSD. Re-experiencing intrusive memories. So parts of the memory are getting stimulated too much. All these memories of whatever traumatic event occurred keep popping into awareness. They haven't been put into long-term storage in the normal, healthy way. Nightmares are re-experiencing phenomenon, and flashbacks are re-experiencing in such a way that the person feels as if the trauma is happening again, right now, in real time. As we're learning more about the pathology, about what's happening in the brain, someone undergoes a traumatic event. And these are life-threatening events. Rape, being involved in World Trade Center, 9/11, motor vehicle accidents, things where you could have died. In the person susceptible to developing PTSD, and by the way, Mount Sinai did a study of most of the people, they were able to get most of the people involved in the World Trade Center on 9/11 involved in the study, looking at whether or not they developed PTSD afterward. The vast majority did not, which contributed to our already existing understanding that it's not the trauma itself that causes PTSD. It's whether you have the vulnerability to develop PTSD in response to a trauma. See, there's a difference. It looks like, and knowledge about this is increasing all the time, that an example of a vulnerability is in the hippocampus. Right? Hippocampus, memory, mood regulation. And I mentioned way back in the first lecture that a person exposed to child abuse or neglect, the effect tends to shrink the hippocampus. That person is later more vulnerable to the development of PTSD, right? It looks like those people who develop PTSD in response to a trauma probably had small hippocampi to begin with that made them vulnerable. Now, the hippocampus is intimately integrated into the amygdala. They have lots of connections. The pathology of one affects the pathology of the other. So you see the irritability, the excessive fear, the anxiety, the emotional outbursts. Now, one hypothesis is that the memories of the traumatic experience that in all of us would immediately be laid down in the hippocampus are supposed to then be relayed to the prefrontal cortex for long-term storage. There's some evidence that in PTSD, they're stuck in the hippocampus. They're not able to be transferred for whatever reason, not understood yet. And so they're there to continue to pop into awareness. Let's see, the re-experiencing symptoms.
But there are also the elements of possible godlike and omnipotent feelings in people with PTSD, going that other direction.
I don't think
I
so.
was reading that in Activities in Vietnam, that book that's about PTSD, about the psychiatrist who interviewed Vietnam vets and talked about the godlike syndrome. These guys who became convinced because they didn't die, but they couldn't die. And those were the guys that the rest of the platoon would follow into battle because they felt like they couldn't die, and they would diagnosed later on after coming back with PTSD.
Yeah, I'm not familiar with it, but it sounds interesting. In generalized anxiety disorder, the person is anxious about everything all the time. Restless, easily fatigued, difficulty concentrating, irritable, muscle tension, sleep disturbance. The anxiety is just infectious. You don't want to be around these people because you begin to feel anxious. Treatment can be effective. Again, teaching them CBT, some medicines. You know, in all of the anxiety symptoms, by the way, I just want to connect it to the substance use disorders. The most commonly prescribed medicine for the anxiety disorders, inappropriately, benzodiazepines, particularly Xanax. Incidentally, the vast majority, 70–80% of what's called psychotropic medicines, the medicines that are used to treat mood, thought, behavioral disorders, right? Medicines prescribed by psychiatrists. The vast majority are written by internal medicine doctors, family practitioners. We only prescribe a small fraction of them. Xanax is one of the most commonly prescribed medicines. Over time, it makes anxiety worse. It sensitizes the anxiety system. Initially, it's great, douses that anxiety beautifully. But then it begins to wear off. It's short-acting, wears off. So now you have the need to take it again. Then it wears off, you have to take it again. So you're constantly chasing the anxiety, but on, off, begins to lower your anxiety threshold. You know, you tolerate less and less anxiety. It feels like you become more anxious over time. And if you have the vulnerability, then you develop benzodiazepine use disorder, right, or addiction. In panic disorder, generalized anxiety disorder, probably helpful if the plan is very short term until I can get this antidepressant, also poorly named because we use those medicines for many different problems. But the antidepressant like Prozac, Paxil, Zoloft, the commonly used ones, they don't work right away. Usually takes a few weeks to get a significant benefit. So in the meantime, it's okay to take a benzodiazepine while we're introducing the antidepressant, giving it some time, and then tapering off the benzodiazepine. But that's not what typically happens. And part of it is because we train you to believe that your anxiety can't tolerate being off the benzodiazepine. Right? Take this, instant relief, fantastic. Oh no, now you want me to try coming off of it? I don't think so. It's hard to convince people to give it up. But what they're depriving themselves of is the experience of seeing that their anxiety doesn't come back because the antidepressant is in place. You know. Personality disorders, I'm only going to cover a couple of them. Oh wow, it's 5 to 6. The major ones that we see here, well, we see all of them. Let me explain what I mean by personality disorder. You know, because of our genes, we are born with what's called temperament. You know, that's sort of the basic foundation upon which our experiences with our primary caregivers, mother, most likely, that relationship begins to formulate our personality. But to the limitations that our temperament has provided. So if we are born with this irritable temperament, then we probably have a predisposition to developing a mood disorder. How mother copes with that irritability will determine whether we get on a healthy track or not. Right? So we talk about the mother-baby fit. You know, a child can develop feeling that he or she was neglected by a parent. But if you had the opportunity to examine the relationship, sometimes you learn that the mother was a good enough mother, but the child's needs were too great. So the relative difference created the impression that the child was neglected from the child's perspective. You see how that fit is off? A lot of child psychiatric research has revealed those kinds of things. So, starting with temperament and then being affected by the environment helps create what we call personality. And that is that pattern of perceiving, relating to, and interacting with the environment. And that pattern can be characterized by coping mechanisms. In psychiatry, we call them defense mechanisms. By the way, you'll hear me talk more about this in community in the introduction tomorrow. But it's the concept that we are mostly driven in our day-to-day behaviors to keep our anxiety to a minimum. Anxiety drives us. We need to have anxiety. Anxiety is that thing that makes us aware of what's going on in our environment. We never want to get to zero anxiety. It means we're dead. We need some. Like our body temperature, we don't want it to be excessive. We don't want it too low. We don't want our body temperature to be 92 degrees. We don't want it to be 103 either. There's a healthy range. That applies to every aspect of us, including our personality features. Personality helps determine the nature of our relationships. We're social beings. We need to be able to relate in a healthy way to the people around us. What's it mean? It means perceiving that other person accurately, developing an emotional response, giving that some meaning, and having it inform the way we then behave or respond to that person. Right? Those are the ingredients to a relationship. How we do each of those functions is determined by our personality. We need, in the healthy individual, we easily adapt to the people around us in order to prevent conflict. Oh, you're treating me that way, or you want to focus on yourself? Okay, let's focus on you, kind of thing. If I say, no, we're not going to focus on you, we're going to focus on me, right? Immediately we create conflict. That's not going to be productive, so we learn to adapt. Unless we're more rigid in our ways. Rigidity starts to create this thing we call personality disorder, not able to adapt to whatever our environment is presenting us with. The defense mechanisms. Now, I'm trying to keep my anxiety to a minimum. So you're presenting me with this experience. I need to defend myself, and I'm going to defend myself in certain ways. You're saying this about me. I'm going to deny it. You're telling me I have an alcohol problem. I don't have an alcohol problem. Right? I'm denying it. If I were to accept that I have an alcohol problem, that's going to raise my anxiety. Oh no, I have an alcohol problem, you see. So that's just an example of a coping mechanism to keep my anxiety to a minimum, a defense mechanism. I think you have an alcohol problem. So now I'm projecting what's really my problem into you. It's not me, it's you. That gets it away from me. Again, another way of decreasing my anxiety. And on and on and on. There are multiple different types of coping mechanisms. So you see, you tend to see certain types of coping mechanisms kind of living together in various individuals. So a constellation of coping mechanisms that seem to be common to these people we call borderline personality disorder. These other types of coping mechanisms, you tend to see them commonly in this person we call narcissistic personality disorder, et cetera, et cetera. Let's skip that one. Skip that one. Skip that one. Oh, antisocial. Let's give you an update. Jim, our coordinators are going to do their very best. We've dealt with worse. Maybe. All right. Antisocial personality disorder. This is the person who not only breaks the rules because they apply to you, they don't apply to me, but doesn't care about how you're affected by him breaking the rules. No remorse, essentially. Now, breaking rules, lying, stealing, cheating, sounds like a lot of your family members, right? Addiction maximizes this. Addiction creates this. Not this particular disorder, but the antisocial behaviors, otherwise known as sociopathy. Right? Addiction does whatever it needs to do to keep itself alive. Lying, cheating, stealing, they go hand in hand. The difference between that caused by addiction and this is that when you treat the addiction, all these behaviors melt away. It's gone. So that person doesn't have a primary antisocial personality disorder. That person has addiction-induced sociopathy. That's treatable. That's not. There's nothing we can do for that person. In fact, having that person in the program is toxic to the program. He'll infect other people with the sociopathy, take other people out. Right? It's in his best interest to get people to do things for him, to exploit them, to steal from them, to convince them to leave with me. Let's go use. Let's go steal, etc., etc. One day we may have treatment for this. We don't now. There's no effective treatment. We've had, I think, 3 or 4 patients since we've opened the program that we've been able to identify pretty confidently as primary antisocial personality disorder. We get them out. Nothing you can do. The borderline personality is very common. This is the person who is in constant fear of real or imagined abandonment. You see unstable and intense interpersonal relationships. There's a famous book written describing this very nicely, and the title is I Hate You, Don't Leave Me. So you see the apparent discrepancy. Unstable self-image, impulsivity, recurrent suicidal behavior, self-injurious behavior, this parasuicidal behavior, threats to kill herself, and it's very common. In treatment anyway, you see more females than males. Often the self-mutilating behavior is an effort to control you. If you leave me, I'm going to kill myself, kind of thing. If you leave me, I'm going to cut myself. You left me. Look, I cut myself. Look what you did to me. Yeah. You see a lot of that kind of thing. But sometimes they go a little too far, inadvertently, and they kill themselves.
That is the worst named illness in the whole world, I think, isn't it? I mean, no one understands. You could ask everybody, sure, no one's going to be able to explain what the borderline is. What you've tried to explain, we're too dumb to remember. What does it actually mean, borderline? What is the border? Let's talk about that.
Yeah, I'm going to explain.
Okay.
From a now let's go back to 1880s. You've all heard of Sigmund Freud, right? Father of psychoanalysis. He discovered the unconscious. And by the way, it is unconscious, not subconscious. Subconscious is a lay term. The clinical term is unconscious. Everything we're aware of, that's conscious. What we're not aware of, that's going on in our brain, is unconscious. We are aware of a tiny fraction of activity that's going on in our brain. The overwhelming majority of what's going on is unconscious. I'll give you an example of that. I've used this example in this room before. I'm about to bring into your consciousness a sensation that you're experiencing right now, but you're not aware of it. And that is the sensation of your rear end against that seat. I just brought it into your awareness. Now you feel it. You didn't just sit down. You were feeling it a second ago, but weren't aware of it. Have I proven the existence of the unconscious? We can go on and on and on until I do. Now there's no doubt about it. We know the unconscious exists. Oh, and there are beautiful studies using functional MRIs. Got to go off on this tangent. You know now that in the person who is about to relapse, or even beginning to relapse, the person who's been triggered, that hippocampus is stimulated, and then there are paths that, through the neurons, going to that ventral tegmentum that stimulates the release of dopamine in the nucleus accumbens, creating craving. I want to use. Well, look, there are studies in people with addiction, clean, not experiencing any craving, no intention to use. They're put in a functional MRI machine, watching slides, and we get to see the activity in the brain. Throw up these neutral slides, sheep in a meadow, a nice sunset, all of a sudden drug paraphernalia. Boom, the nucleus accumbens starts turning on. Are you having any craving? No. We've just triggered it. It's unconscious. It's happening. Compare that to then the person experiencing craving, you see the same thing. So we know that activity means craving. The person is having unconscious craving at that moment. It's fascinating. In fact, I tell the patients that one day, I think that we're likely to have some type of portable functional MRIs that we're going to have in our office, and it's going to help determine when we move them from PHP to IOP. It's going to be fascinating, right? Yeah, just see the high tech coming in the future. So, Sigmund Freud and the unconscious mind. He also talked about the id, the ego, and the superego. The id, that part of the brain that's responsible for driving sex and aggression. Remember those basic drives I talked about earlier? The superego being the conscience of the mind, the moral arbiter, right? Helping us to know whether a behavior that our id is driving, look, I want to have sex with that person. That's the drive, that's the desire. And the superego kicks in and says, no, that's not a good idea. You're married. There are lots of reasons why you shouldn't do it. It's a bad choice. Inhibit that impulse. The ego moderates between the superego and the id and interacts with the environment. So, I experience this sexual craving. I suddenly have the thought, no, that's bad. The ego says, all right, let me compromise for you. I'll let you engage in sexual behavior, but it has to be with your spouse. Satisfies the superego, satisfies the id. This is all work that Freud espoused as a hypothesis. Throughout the development of further psychoanalytic research, the concept of personality that we talked about earlier was described in such a way that the normal, healthy individual was seen as operating on a neurotic level of functioning, as opposed to the psychotic level of functioning. The psychotic person can't tell the, I forgot to define this for you, I'm sorry. Psychosis is the state in which you cannot tell the difference between what's real and what's not real. Another way of saying that is there's no good boundary between what's coming from me and what's coming from the environment. Remember that symptom, hallucination? It means I'm experiencing the effect, I'm hearing a voice, but there's no stimulus in the environment, so it's a hallucination. You see, I can't tell, is something coming from inside my head or from the environment? If I tell you, I'm hearing voices from out here, there's no boundary between inside and outside. So that's psychosis. So people were divided between whether they were operating on a neurotic level or a psychotic level. Well, what about these people? Sometimes they look like they're neurotic, sometimes they look like they're psychotic. Well, they're right on the border. In fact, under stress, sometimes they do dip into psychosis. But not like schizophrenia or bipolar disorder, not that severe. It's just some difficulty distinguishing what's real and what's not real. They'll accuse you of paranoid types of things. And you know it's not true, but you're the psychiatrist in psychotherapy talking with the patient, and the patient was saying, you just blinked a little too fast. Does that mean you're going to stop our session? That kind of thing. Now, you recognize that that's odd thinking, right? That's sort of a mini psychotic thought. So they can dip into psychosis under stress, but most of the time, and they're not functioning at a high enough level that they're doing well in society, so they're not neurotic. Neurotic meaning healthy. They're right on the border. Borderline personality, yeah. The histrionic personality is overly dramatic. Everything is to the extreme. The narcissistic personality is the most commonly associated with addiction. This is the grandiose person, just formulating relationships in terms of how you can be used by this person. Always wants to be the center of attention, believes he or she is special and unique, requires excessive admiration, has a sense of entitlement, I don't have to stand in line kind of thing, lacks empathy. This person when you're talking to him, or there's a strong suggestion that person has a narcissistic personality because you don't feel like he or she is interested in you. You're simply an audience member. It seems like you're relating to one another, but he's placing you in a position of just admiring him, listening to him. Let me talk to you about my great attributes. And by the way, okay, we've talked so much about me. Let's talk about you. What do you think about me? Yeah? Let's see. Yep. Those are the major ones. So just a few things before we stop. Go ahead.
So when you touch a little bit on somebody who has an autism spectrum disorder in association with, is it possible to have a dual diagnosis as far as bipolar and autism disorder, or is it just autism is the main issue, or?
Yeah. That's one of the major syndromes that I omit in this lecture, only because we don't tend to see much of it. We do, like on occasion. Now, this phenomenon of autism spectrum disorder is essentially impairment in social interaction, being able to read facial expressions, being able to put oneself in the other person's shoes, understand their perspective, also recognize how the other person is being affected by him or her. Sometimes you see a speech delay, sometimes you see mental retardation. Not necessarily, though. Having autism doesn't protect that person from developing other psychiatric syndromes. So you can see mood disorders, psychotic disorders, anxiety disorders, substance use disorders. Yeah.
Would you say this, the spectrum seems to cross over so many different disorders? Like you could kind of take, little things like anxiety or narcissistic behavior, from each of the different ones. So I didn't know if it was just one encompassing title for somebody who might have more than one issue.
Right.
Or if it was possible to be autistic and one specific.
Yeah. There's still a lot of research trying to understand what autism is. We can describe the common features and tend to be related to the social relationship. But that doesn't really say much about it. It doesn't say its cause. We don't really have an effective treatment. When we see symptoms that are related to other psychiatric syndromes like mood disorders, anxiety disorders, we try to treat, it's called symptomatically. If a person is excessively anxious or seems to be persistently depressed, then we may give an antidepressant medicine to try to help those specific symptoms. It's doing nothing for the autism, but it's just trying to decrease the intensity of related symptoms. And where to draw a line between, what might be related to the autism versus what might be related to a completely different psychiatric syndrome. That's what we've been trying to do in psychiatry for 120 years now. I mentioned the DSM-5, the Diagnostic and Statistical Manual of Classification of Psychiatric Disease. Right? That's an effort made to categorize symptoms into a meaningful diagnosis. Research has shown that when people are experiencing a depressed mood and a sleep and appetite disturbance, they also tend to have concentration impairment, they feel worthless, they feel helpless, they feel suicidal, hopeless. Right? These symptoms tend to go together. And since in study after study after study they go together pretty reliably, let's say that this is the syndrome that we're going to call major depression, and then follow that over time. Does that group of symptoms, if we see that in an individual, does that help us to predict prognosis? Is that person who's experiencing all these symptoms and we are sort of arbitrarily choosing to call it major depression? Are they more likely to respond to this medicine that now we call an antidepressant medicine? So we try it, we study it, we see, yes. So we were right in putting those symptoms together, right? And this is how the DSM has evolved from DSM-1 through now DSM-5. I don't think there are any diagnoses in DSM-5 that we called the same thing in DSM-1. Maybe schizophrenia. Yeah. Learning all the time, and our classification system is evolving all the time as we're trying to learn more and more about the pathophysiology, right? The biology that I'm teaching you about the brain and what parts of the brain are involved in different functions of the brain, this is just based on knowledge that has been gained over the past 20 years. We didn't know any of this when I was in medical school. None of it. Very important. Jackie had explained to you that tomorrow we don't want you to give anything to your loved ones. I want you to understand the concept behind it. Most of your loved ones suffer from addiction, at least. Some of them are unlucky enough to have comorbid diagnoses, bipolar disorder, schizophrenia, etc. In addiction, it certainly is partly driven by risk-taking behavior. Risk-taking behavior, or taking risks, rather, is involved in breaking rules, breaking the law, trying to obtain that drug. We all, naturally, as human beings, are more likely to take a risk when there's a safety net. Right? Think about being up on that high wire. Most of us would want to give it a shot, knowing the worst that can happen is I'm going to fall into that net, bounce around a little bit, it's going to feel good. We're more likely to take risks. Most of your loved ones who are suffering from addiction began using the substances in adolescence. In adolescence, it's a time where, by the way, there are a lot more than those 10,000 dendrites on each of those axons. But our brains have evolved in such a way that now our genetics determine that during adolescence, a lot of those extra or superfluous dendrites need to be pruned. They need to be trimmed, making the system more efficient. the last part of the brain to develop, the prefrontal cortex. So these 13, 14, 15-year-olds making a choice to smoke marijuana, start drinking, try that cocaine, right? They don't have a developed brain. And what's not developed is being exposed to a toxin. So what do you think happens to all that pruning that's supposed to be occurring? It's a mishmash. It's like you went through with some type of chainsaw, right? Rather than pruning shears. So that naturally affects development. In the process, as they're getting, late teens now, in healthy development, it's a time in our society, our culture now, where we're supposed to be moving out of your home and learning how to become independent, right? We're going away to college, or we're going into vocational school, or we're learning to work at a job to be independent and responsible for ourselves. That's still part of development. No longer depending upon you. Addiction messes that up. It takes that person off that track. Maintaining that pathologic development upon you to keep it alive. I can't learn responsibility, obligation, regulate my self-esteem in other ways, and be an active addiction. They don't go hand in hand. It's one or the other. Now, in most cases, you have tried everything you could possibly do in your well-meaning ways to help stop your loved one from using. Most of the time, most of what you've done has actually helped to maintain that addiction, and you haven't even realized it. We recognize it easily, and we're teaching you how to recognize that. Your actions provide tremendous psychological meaning to your loved one. If you were to offer a piece of gum, there's only one message that unconscious part of the brain is receiving, and it has nothing to do with that gum. That brain is saying, son of a gun, she's still there for me, providing that safety net. I'm taking a risk. That's exactly what happens. The slightest behavior, it seems completely irrelevant. Addiction has trained their brain to look for opportunities. You've experienced the results of that. And we learn it more and more every day from them because they're constantly sharing. What was going through their mind when they made this choice involving you, when they made this choice involving you? They've taught us everything we know. We're trying to teach you. So you give nothing. Now, they know, because I told them, and I tell them right before every family weekend, if you do offer anything, they have to raise their hand. So staff can come over immediately. We consider that an emergency. You offering a piece of gum is one step before them sticking a needle in their arm. That's how we perceive it. And that's why we treat it like an emergency. By the same token, if they ask for anything, and I mean anything, you have to raise your hand so that we can run over to you to intervene. They will test you. One of you at least will be asked to use your cell phone. Worse, to take you home. To take them home, rather. This place is horrible. They don't feed us. They don't give us anything to drink. The apartment is infested with cockroaches. The toilet doesn't flush. Any type of, they're looking for your facial expression to know whether they got their foot in the door, now run with it.
Never plan. walk in the room.
Would you mind, we had a few mishaps the last time of the weekend, because some of the newer parents didn't think to ask for a counselor to sit at the lunch table.
Oh, yes. Oh, thank you.
And so these are probably all the new people. But I think we should probably overtly say, if you think your son or daughter is going to ask you for crazy stuff, have somebody sit with you at the lunch.
Right. Yes, if you feel there's the slightest possibility that you might be vulnerable to that, then you make sure that you are either sitting with a staff member or another healthy family. And you will learn who the healthy ones are in tomorrow's community meeting. You will also learn who the unhealthy ones are.
You had made reference about donating a piece of gum. If they ask you for like a hug or something, is that off limits as well, or?
Yes, a hug is what we want them to ask you for. Absolutely. Yeah. Talking about material items.
But we can give them a hug.
Yes. However, now we have this all choreographed for psychological reasons. You'll come in, this is gone tomorrow. It's one big open room. You'll come in and you'll be instructed by the staff to sit somewhere in the room. Now, if you're together with family members here, you want to be as diametrically as opposed as you can in the room. And there's no physical contact. The patients will come in and they're told to go right to a seat, they're to identify where you are and then sit as far away from you as possible. We create this for an effect. We don't want them to walk over to you, to kiss you, hug you, talk to you, nothing. Now, think about this for a second. They've been looking forward to seeing you. This is creating intense emotions. We want to harness that. We don't want it to get expressed in their behavior toward you. We've lost an opportunity. We want it to get expressed in words. So not only you will hear it, but the entire community is going to benefit from it immediately. You'll appreciate that when you're seeing it in action. Possessions. What do you think the message was sent to the intended recipient of this? Notice the tag? What's that tell you? It's new. What's the message to this boy? Say that loudly.
Keep doing what you're doing, I'll keep giving you what you need.
I'm sorry? Say it again, loudly.
Keep doing what you're doing, I'll always be here to get you what you need.
It didn't stop there. Brand new. By the way, those of you who know me know that I don't do these things to embarrass people. It's to teach you. And I have to create a significant emotional reaction in you in order to teach. The note. Sorry, the box was in my front seat and the sun was beaming in. They got a little melted, but I sent them anyway. Handwritten. You love you some Cholula. What's the message? Haribo gummies. How old do you think the intended recipient is? Mom, how old is he?
Talking to me?
Mm-hmm.
I didn't send that to my son.
Came from you.
I didn't send that.
I have the box here.
He's nervous to see though.
Guess who wants to leave? Treatment. He's been in transitional, expected to look for work, to look for a job. He hasn't. Why? Because family weekend's right around the corner. Guess what happens at family weekend? Now, do you intend to take a tot home? Now, this is a fascinating phenomenon because I believe that that is her conscious intent. But her son knows her better than she does. What does he know about her unconscious mind? You better believe it. Yep. And that's what you're going to see happen this weekend.
Would you say what you said again?
That she'll do everything and anything for him without even him having to ask. It's one of the hardest parts is we do love them and they can manipulate us so easily without even doing anything, you know, and the tough love part is the hardest part.
Do you know that in the 4.5 years that we've been open, they've never been wrong about you? Never. Never. How many family weekends have you been to? 11. Every single patient who was absolutely determined the parent was going to take them home, the parent took them home. Maybe not tomorrow or Sunday, but within the next week. Because what happens is, even for that strong parent who's able to make it through the weekend and then get on that plane on Sunday and fly home, doesn't stop the patient. Yeah, nice show. Patient leaves, calls, and convinces them. Buy me a ticket. And it happens. It has happened every single time. And it's happened with at least one patient every single family weekend since we opened.